everyone. Welcome back to Plant-Based Kidney Health. My name is Michele Crosmer, and I'm a renal dietitian, and I'm here with Dr. Sean Hashmi. Okay, so we're on episode 11, and we are talking about phosphorus, which is a huge topic. We might break it up into 2 different episodes, depending how much we're able to get through. But phosphorus is something that can be confusing. There's a lot of misconceptions and myths or misinformation out there. So we are going to address as much of it as possible, talk about diet and phosphorus binders and all of that. So I think a good place to start, if you can just explain what phosphorus even is and why it's something that is so important for kidney health.
Yeah, so this is such a loaded question and there's so much information here. So what I'm going to try to do is hit on some of what I think are going to be the most important highlights for people to know about, to understand, and to take away. So the first thing you want to know is when it comes to all of the elements inside our body, phosphorus is actually the 6th most abundant element inside our body. Now, it's important in so many things. The most common one everybody talks about is of bones. And so it's needed for building strong bones. Bone mineralization is the medical word we use. But what people don't realize is it's also needed for forming our cells. It's needed for forming our genetic material. That means our DNA. That means our RNA. And the most important thing that people forget is it's needed for energy. So, for example, when you exercise and you're taking a deep breath and you're taking those breaths and your lungs are moving, well, that is ATP. And ATP, the 3rd letter, is phosphate. So it's really, really important. Now, what's fascinating about phosphate is we actually have a lot of it in our body. In fact, we have close to about 1,000 grams that are sitting inside our body at one time. But where each part of that phosphorus is really important for all of us to understand. So the first place is the bones. Now, the bones are going to have anywhere between 80 to 90% of that phosphorus. So when we were talking about that 1,000 grams, think about 80 to 90% of that sitting right inside your bones. And not just that it sits inside your bones, every day it moves in, it moves out. About 300 milligrams is going in and out on a daily basis. So that gets rid of that big portion, but the other portion, about 10 to 14%, is sitting inside your cells. So remember, when you go and do a blood test, it's only looking at the phosphorus outside your cells, what's in the blood. That's called extracellular. So extracellular is only 1%. So why should you care about all of this stuff? It's because when we talk about phosphorus, we forget the fact that phosphorus can move in and out of the cells for different conditions. And you want to know that going on. And so I know, Michele, we'll get to the question where you're going to talk about sort of the phosphorus intake, the types of phosphorus and so forth. But really, in terms of CKD, it's really, really important to talk about phosphorus restriction because as you see what the impact is, you can understand why it's so critical. So let's dive into first high phosphorus, then let's dive into low phosphorus because you want to understand both. High phosphorus is the one that everybody understands in kidney disease. The doctors are all over it. The nurses, the dietitians keep telling the patients about it. So why should you care? Because as your kidney function declines less than 60, a lot of things start to happen inside your body that have no symptoms whatsoever. So the big term that we give it is called CKD MBD. That's a fancy word. It stands for chronic kidney disease, right? Mineral bone disorder. So that's CKD MBD. And what happens in there is a series of events where first you start to have basically excess phosphorus starting to build up in your body. Why the excess phosphorus building up? Because as your kidneys worsen, they can't get rid of it. Remember, your bones can hold on to some phosphorus, but that reservoir gets filled very, very quickly. Your cells can hold on to some, but that reservoir gets filled. So as a result, what ends up happening is as phosphorus starts to build up inside your body, something very interesting and scary happens. And that is there's a gland back here. It's called the parathyroid gland. And that parathyroid gland actually starts to get stimulated. And the reason it gets stimulated is because it makes a hormone called parathyroid hormone, hence the parathyroid gland. Nothing to do with the thyroid gland. This is back. There are 4 tiny glands back here. They're called the parathyroid glands. Now, as those parathyroid hormone starts to secrete, so you start to build up phosphorus. The phosphorus goes and signals your parathyroid. The parathyroid says, I got to get rid of this phosphorus. So it actually makes this hormone parathyroid. But this hormone doesn't just get rid of the phosphorus from the kidneys. It does a bunch of things. It starts to leach out calcium and phosphorus from the bones as well. So a lot of patients who have kidney disease, who have higher amounts of phosphorus going on, they suffer from a condition called renal osteodystrophy. There are two kinds of bone disorders that occur in kidney patients. One is soft bone disease, or what we call osteomalacia, and the other one is osteodystrophy, which in simple terms is brittle bones. Either you have soft bones or you have brittle bones. Those both break very, very quickly. So as you can see now, as the phosphorus is going up, you're creating this whole structure and this whole cascade that's leading to bone problems. But that's not where it stops. The other stuff that starts to happen is as that kidney function continues to decline, when you take vitamin D, we call that version of vitamin D from the sun or from over-the-counter supplements as the inactive form. In the kidneys, it gets converted into what we call the active form. And that active form comes all the way up here, feeds back and tells the parathyroid gland to calm down, to not put out so much parathyroid hormone. But as kidneys get worse, the kidneys can't convert to the active form no more. So now some of those feedback loops that were trying to control this whole bone mineral disorder in check, they're all gone. So all of this phosphorus is starting to damage your bones, but in addition, it starts to complex or it starts to bind with calcium, and you get calcification. And this calcification doesn't just affect your blood vessels. It goes in your heart, it goes inside your arteries, it goes in your joints, it goes inside your lungs. This is why when we do x-rays on patients who are on dialysis, for example, we can make out all of their blood vessels for that stuff going on. And the end result is a lot of these patients who have high phosphorus levels, they start to have bone pain. And this is the kind of pain that no matter what you do, you cannot get it to go away. It's really hard for us as nephrologists to see a patient who's suffering because none of the usual pain medications really help with this type of bone pain going on. And then the other thing that is really, really severe and it prevents you from sleeping and everything else is the itching. People who have high phosphorus, they will tell you, Doc, I can't stop itching. And I have to tell them, the only solution to your itching, Mrs. Jones, is you have to control your phosphorus going on. So the flip side to this equation is if you actually lower the phosphorus, and we'll get into that in a second, but if you do it with food and or if you do it with binders, you can actually fix some of these parathyroid issues, especially before they get completely out of control going on. So that's where hyperphosphatemia is such a big deal because it increases your overall risk of death. Now with hypophosphatemia, which is the opposite, that stands for low phosphorus going on, what you want to know is the only way to get low phosphorus is through two ways. One is if essentially you're not getting enough in. The other way is if you're getting rid of too much. And by getting rid, I mean it could be because in the short term, meaning acutely, you're shifting the phosphorus inside cells, or in the long run, you're just wasting it through your kidneys going on. So the way we tell is which one is which is very simple. Your kidney doctor will say, Mrs. Smith, we're going to have you collect your urine for 24 hours. And by measuring how much phosphorus secretion is happening inside the urine, we can tell. So what we're looking for is if you have low phosphorus, we expect your kidneys to hold on to as much phosphorus as possible. So if we see that the percent secretion of phosphorus is greater than 5%, then the kidneys are not working right. They're actually going ahead and secreting too much phosphorus, and that's an issue. So if you have this hypophos or low phosphorus, what are the things that are concerning? What should you know? First thing is people oftentimes they present with confusion or just simple disorientation. They can't kind of make out where they're at, what's going on. But in severe cases, what we've seen is things like comas is things like seizures going on. Of course, hypophosphatemia will weaken the bones. But what's really interesting and scary is it can also lead to heart failure. And by correcting the phosphorus, you can actually correct that. You can also have things like muscle pain, and some people have numbness going on. But really, the big stuff is hypophos, just like hyperphos. Both of them. So in other words, too little or too much of anything can oftentimes be bad for you. So the biggest causes when we talk about this stuff is really, first is malnutrition. And malnutrition happens especially as people get older going on. But this gland up here that we talked about, this parathyroid gland, when it becomes overly active, we call that hyperparathyroidism. Its job is to tell the kidneys to get rid of phosphorus. Now, if it does that too much, you can also get low phosphorus. We make a big deal in our kidney patients to make sure that they take vitamin D. And the reason for it is if you're deficient on vitamin D, remember, you can block that feedback that you need going back there, and you can get that hyperparathyroidism, which will cause phosphorus to leave the body. Other stuff that you want to know about that really isn't all that common, there's a syndrome called hungry bone. Sometimes when these four glands, the parathyroid glands, are so large and you've left it alone and you didn't want to have surgery, finally when you get surgery done, the bones have been deprived of calcium and phosphorus from so long that all of a sudden they'll start to suck all of the phosphorus back in, and we call that hungry bone, and that can actually be very, very dangerous. And then the last thing is antacids. So a lot of people that are taking antacids, of course, we use Tums as a way of controlling phosphorus, but other antacids do the same thing, is they can cause you to have low phosphorus. Same thing with diuretics. Diuretics will cause you to lose phosphorus in the urine. So as you think about phosphorus, there's a lot to understand, but just remember, high phosphorus or low phosphorus has devastating effects on the body, and that's what you want to take away. So let's get it.
I was just going to say with that, it's so much with phosphorus, and I think that's such a great explanation. And honestly, people should replay that a couple times to hear that explanation, or even online. There's good images that show the relationship between the parathyroid glands, vitamin D, phosphorus, calcium, and all the different feedback mechanisms that, help show it visually, that I would suggest looking at while you replay what Dr. Hashmi was just saying, because it's confusing, but I think one of the biggest takeaways from it is, you don't want super low phosphorus. You don't want high phosphorus. I think from what I see more commonly is usually the high phosphorus compared to the low phosphorus. But the other thing too is, and I think so that we're relating to people across all stages of kidney disease, is that usually the high phosphorus, at least, we usually see in later stages of kidney disease. But it doesn't mean if you have stage 1, 2, 3, or any stage and your blood phosphorus levels are perfect and normal, it doesn't mean, okay, well, screw it, I can, eat as much phosphorus as I want, or it doesn't matter the sources of phosphorus in my diet, because some of these, all of this is still going on, where if you're consuming excessive phosphorus intake and your body is having to increase how much phosphorus is excreted, and the parathyroid hormone can be impacted. So it's all related, and it is relevant across all stages of kidney disease, whether you have high or low phosphorus blood levels or normal levels.
Yeah, so Michele, you touched upon a really important point. So let me stress this one more time. So when you get below a GFR of 60 and you say, doc, my phosphorus is not going up, should I be concerned? Absolutely. The reason is because the reason your phosphorus is not going up is this gland back here, the parathyroid gland, is becoming more active to keep up with the fact that the kidneys are not getting rid of the phosphorus. So by getting this gland active, it makes the kidneys do more stuff to get rid of the phosphorus going on, but it's already starting to impact your bones. So in other words, it's a mistake to just look at your phosphorus level and say, well, my phosphorus is okay, so then it's fine if I'm drinking all that milk, if I'm eating all that cheese. The issue there is there's stuff that's already happening in your body. Just like by the time you see your creatinine finally starting to increase, you can lose as much as 40% of your kidney cells. So this is why when we say things like have a good blood pressure, exercise, do all these things, whether or not you see that kidney function worsen or not, is because we know that if you wait till the numbers actually show it, there's all this damage that's already occurred.
Exactly.
Okay, Michele, so let's get this question for you. Let's talk about the different types of phosphorus, and can you kind of touch on what are the absorption rates? And then as you're thinking about absorption rates, which type of phosphorus, or should all type of phosphorus be avoided? And if you're going to avoid everything, how the heck do you kind of track how much phosphorus you're getting?
Yep. And that's why phosphorus is confusing, because as from a tracking standpoint, it's not, phosphorus is not required to be on the food labels. It's oftentimes not in populating in a nutrient database. If you're tracking your food, or if you're scanning that food item, it'll just come up as 0 milligrams of phosphorus. So to break it down first, there's 2 different types of phosphorus. There's inorganic phosphorus, organic phosphorus. But to make it simple, the inorganic phosphorus is the phosphorus additives that are basically used as either flavor enhancers or preservatives in food products. And so to find that phosphorus, it has to be listed, at least in the United States, it has to be listed as an ingredient. So you're not going to see it on, phosphorus, 500 milligrams. It would be listed in the ingredient list, and it's anything with a PHOS in the name. So it could be phosphoric acid, which is commonly in dark colored sodas. It might be what is it? I've even seen hexaphospha, anything PHOS, disodium phosphate can be used in certain deli meats or injected into meats. And so anything PHOS in the ingredient list, that's a phosphorus additive, and that's really absorbed usually around 90 to 100%. And comparing that to the 2 organic types of phosphorus is the phosphorus coming from animal sources, and then we have phosphorus that's coming from plant sources. And this is phosphorus that's just naturally found in these food products. So the animal sources of phosphorus is, all of our meat and poultry, fish, eggs, dairy, and the absorption rate varies, anywhere from 40% up to 80%, especially for dairy and cheese. That's the absorption rate of that phosphorus. And then we compare that to plant sources of phosphorus, which are things like our whole grains, nuts, seeds, legumes. That's absorbed sometimes as low as 10% up to, maybe 30, 40% typically. And so when we look at those 3 types of phosphorus, the phosphorus additives, which is, one usually in highly processed food, and is absorbed 90 to 100%, that's typically, if you can eliminate that from your diet and choose products that don't have that, for example, corn tortillas, right? They commonly have phosphorus added, but there are brands that don't have phosphorus added. And so if you are choosing food items that don't have phosphorus additives, you're helping to remove a good amount of phosphorus that the body absorbs and can be absorbing in excessive amounts. Then, of course, one of the biggest perks for people with kidney disease of a plant-based or plant-predominant diet is that the plant sources of phosphorus are a lot less absorbable than the animal sources. So if you were to substitute some or all of your meals where you're substituting beans or tofu or legumes, whole grains, nuts, and seeds for the animal protein sources that are high in phosphorus and higher in absorbable phosphorus, then overall, we typically see people have an easier time controlling their blood phosphorus levels in that case. So that's, the different absorption levels with that. And then as far as, that just helps with tracking, because I think there's a lot of times with kidney disease, there seems to be so many different micronutrients, I need to track sodium, potassium, phosphorus, protein, and it gets really overwhelming. So what I usually recommend is first, check your labels, avoid the phosphorus additives. Second, work on implementing a more plant-based, plant-predominant diet, because if you do that, you're just naturally reducing the amount of absorbable phosphorus that you're consuming. And then you really don't need to be tracking the milligrams of phosphorus, which is honestly, it's near impossible because it's not always going to be the most accurate. If you have your bread and you scan it and it says 0 milligrams of phosphorus. Well, that's not true. It's not 0 milligrams of phosphorus. And to actually calculate, well, I only absorbed 100 milligrams of this and I absorbed 90% of this, that's just really confusing. And so, again, avoid the phosphorus additives, try to do more of the plant sources, and that overall will help you have a more adequate phosphorus intake and then have less absorbable phosphorus in your diet.
I love that. And the message is so simple. So just eat a plant-based diet. If you can do that, that's great.
Yep.
If you're not there yet, that's fine. No judgment here, judgment-free zone.
Yeah. Yeah. And even just working towards it, right? Like it might be if again, we always talk about like actually evaluating and looking at what you're consuming. And that's the thing too with, we know not all phosphorus is absorbed equally and, created equally, but the animal sources of, protein and phosphorus sometimes can have phosphorus added to them, injected in them, used as a preservative. Like sometimes they'll use them instead of using so much salt or sodium, then they might be using phosphorus to preserve instead. And so that can almost be this like double whammy of, okay, well, I'm having, this turkey, but is there phosphorus added? Has it been injected into it? And sometimes it just really adds up and it amplifies. And if you're then having a beverage that has phosphorus additives, it can just add up to be a lot. So if you look at your intake and you at least a couple meals a week, you're making that substitution, that is also helping to lower the phosphorus intake and then working more, towards more meals that are plant predominant or plant-based.
Oh, that's fantastic. That makes so much sense, and it's easy to go ahead and follow as well. So,
yeah. So having said all that, of course, and we can dive more into the diet side of it, but diet is one method of, helping to control how much phosphorus someone, is taking in. But from a medication standpoint, can you explain what phosphorus binders are and how they work, and then at what point they might be prescribed for someone?
Yeah, so of course, whenever we talk about this stuff, the first thing to always remember is diet, diet, diet. The last thing to always remember is diet, diet, diet. So you can't escape a bad diet, right? You can't exercise your way out of it. You can't do anything else. So diet is first, but there is a role. Now, the reason we make such a big deal out of phosphorus is, there was the study that was done that we all learned about way back in the day. It was actually in 2011, and it was a meta-analysis. And what they showed was that for every one point, so 1 milligram per deciliter, so 1 point increase that you had in your serum phosphorus going on, you had an 18% higher risk of death. This is substantial if you think about it. And normal phosphorus levels in your blood, they ought to be about 2.5 to about 4.5. So that's really your starting point. If you start to go above 4.5, the first thing you want to do is focus on diet. Now, according to guidelines, what most nephrologists do is they really wait around phosphorus gets above 5.5 to start the binders. And before that, they really rely on diet. My personal practice, I tend to be a lot more aggressive because of the fact that I know what's going on in the inside doesn't reflect in the labs yet. But generally speaking, your doctor may wait until 5.5. Now, in terms of the types of binders, there's two categories. The first category is the calcium-based, and the second category is the non-calcium based. So let's start off on the calcium based. So what you want to know is there's really two big binders in the calcium category. One we talked about, which is TUMS, calcium carbonate, and the other one is calcium acetate. Now, calcium acetate has been around for a long time. It's got all sorts of names because there are so many companies that make the generic version. So Foslira, Foslo, Elifos are just some of the names that is found under. But when you come to the non-calcium based binders, there's a few. The first one, and the one that's the most common, is sevelamer. And sevelamer is Renvela or Renagel are the common names for it. Another one, and this is a little bit of a newer kid on the block, is ferric citrate, Auryxia. And Auryxia, what's interesting about it is it contains ferric, or it contains iron. And the iron, if you're anemic, it can have a double impact in that it can raise your hemoglobin and also help you to control your phosphorus. So that's where people tend to use it for. The next one is sucroferric oxyhydroxide, which is basically Velphoro. Velphoro's claim to fame was that most pills are really hard to swallow, so Velphoro is chewable. And as a result of it, their whole thing was because it's chewable, people would want to take it. I can tell you, as an experiment, when we were fellows, and this is going way back in the day, our attending at that time would actually make us try the binders just so that we knew what it tasted like. And I took Renvela, and I was so sick. But the one that got me the sickest was actually the last one, which is lanthanum carbonate, is phosrenol. So I've tried phosrenol, but all of these have sort of different things that they try to do. But here's where it becomes really important. When you look at all of these, you got to understand some of the nuances. For example, in Orexia, the reason that I personally don't like to use Orexia is when you have citrate can actually increase the absorption of aluminum. And aluminum can be found in traces in a lot of packaged foods. So it's not necessarily the foods that you're preparing, but a lot of packaged foods can contain it, and you can get it. So in our kidney patients, because they have such a hard time getting rid of it, even though aluminum toxicity nowadays is very, very rare, when we measure it, we can find some patients have higher amounts. So if you're concerned about that, you want to make sure that you're not using citrate-based anything, because citrate will increase absorption of aluminum. But remember, aluminum toxicity, extremely rare. Now, in terms of picking the best binder for you, which one is the best? It's a very, very simple way to look at it. So there's a meta-analysis that was done in 2016, and it's in PLOS One, and basically what they showed was that calcium-based binders overall have a higher mortality than non-calcium-based binders. Period. This is not just that meta-analysis. There's so much data. In addition, I actually hate calcium-based binders. I try to never use them. And the reason is because the concern there is not just that you'll raise your blood calcium levels, but that you can also be contributing to things like vascular calcification. And we'll talk about things like vitamin K2 and kidney disease in here. But what you want to know is your calcium in your blood will bind to your phosphorus. And if you already have extra phosphorus, you don't want to be adding calcium to it, so it binds together, precipitates, and lights up all your blood vessels, your joints, your heart, and all sorts of things going on. So really, in my personal practice, I really try to avoid calcium-based binders. It's very rare that I have to use it, and it may be because the patient has a very severe calcium deficiency. They're very severely hypocalcemic. And even then, all I want to do is use it to the point of getting them into a safe limit, and then add on a non-calcium-based binder if I need to still have better control going on. Then the last question is okay, so we differentiated between calcium and non-calcium, but amongst the non-calcium, which one is the best? Right? And everybody wants to know, why is my binder the best? It turns out the efficacy of all of them is the same. How we pick them is based on side effects and how well you tolerate. So some people will come to me and say, Doc, that Orexia you gave me, I tolerated so well, but you gave me Velphoro and it was horrible. Chewing it made me gag and I couldn't do it. Fine. We know that one doesn't work. So in other words, it's really based on what's going to work for you.
Yeah. And the thing with binders, and it's funny that you had you had to take, try the binders for experiment. I know dietitians sometimes, not that we have to take binders, but more so take some sort of like a M&M or a Skittle, and it's like to mimic taking phosphorus binders with every meal and every snack. And sometimes it's like 3 or 4 pills of like, just so that we recognize kind of the pill burden that it brings. But that's the thing too with these binders is like they are, they're taken with your meal, and they're, they kind of act as like a sponge, and they help to absorb some of that absorb some of that phosphorus so that you're not absorbing that in your GI tract. And they're not it's not like you consume 100 milligrams of phosphorus and the binder is going to absorb 100 milligrams and prevent your body from absorbing any of it. They only, they have a certain efficacy. They work to a certain amount, but on top of that, even someone on dialysis, maybe they're on 4 binders 3 times a day with every meal, the diet is still very important because, the pills they help, they can do, so much, but ultimately sometimes even just the diet can help reduce the pill burden that someone has to take. And so that's where, all of that and the different absorption rates that we talked about with the phosphorus comes into play. But, do you know, and just kind of the last question, but with the phosphorus binders, like how much, or I don't know if you know off the top of your head, but how much they actually absorb, or is it something that's because I always see when I worked in dialysis, it was, phosphorus is still high. And so we keep tacking on, take 3 instead of 2, take 4 instead of 3. But sometimes are people even taking them because of all these side effects that they're having? And it's a pain in the butt, to swallow a bunch of pills or chew a bunch of them. But how much do they actually work?
Yeah. So, this is really interesting because each one of them has a little bit different effects. So in other words, overall control is about the same, but on a milligram to milligram, each one of them is very variable. And there's so many different factors that go into whether or not they're working or not. So I'll tell you, in our clinical practice, for example, what we find is when we have patients who are not doing well with Renvela or Sevelamer, when we switch them to lanthanum, we actually find that we get better control of phosphorus. There's no clinical data that says lanthanum is somehow superior to Sevelamer, but in our clinical practice, we find that that's our go-to when we're looking for better results going on. Valforo, the difficulty is the chewable part makes it harder, but in terms of percentages, I haven't seen the data on it, and that's going to be a good question. So let me come back to that one next time, because I really want to know if I can give you guys some specific studies and data so that it's all evidence-based and not my opinion-based.
Yeah. And really the best phosphorus binder, right, is the one that someone will take and take consistently. So one that, like you said, doesn't have all the stomach side effects, one that you can carry with you or take with your meals. Because even if you have the best phosphorus binder out there, if you're not taking it, then, obviously it's not working. So that's important too. But I think, that's all we can get to with phosphorus today. If you guys have, again, phosphorus is a huge topic, and especially phosphorus and how it relates to parathyroid hormone, vitamin D, calcium. So make sure you guys, you can either comment on the video, you can submit questions to our email address, plantbasedkidneyhealth@gmail.com. Any questions you have, but even specifically on phosphorus, that way when we do a second episode, part 2 of phosphorus, we can address those questions because it's confusing. There's a lot of information about it, and a lot of it gets, specific and scientific and stuff. So we want to make sure that we are, keeping it as simple as possible for you, but addressing your questions that you have as well.
Awesome. Well, thanks so much, guys. We're going to see you next time.